Good afternoon. My name is Emelia Strickland, and today I'm going to be presenting a review of a research article that I'm doing for my SPA 521 class. To begin, I would just like to start with the name of the article that I reviewed, and that is Factors Affecting Early Services for Children Who Are Hard of Hearing. This research study, it was hard to determine the exact design of the study, but I ended up narrowing it down to either a time series design or a longitudinal study. This is just because it could be either of these due to the fact that the participants could have taken the questionnaires that are used in the study, which we'll talk about later. They could have taken the questionnaires once or more than once. So that is the reasoning behind choosing both of those types of designs. And then the purpose of the study is to describe and discuss factors affecting early intervention for children who are hard of hearing. And I also thought that another purpose was to gain a better understanding of the variables influencing outcomes of children who are deaf or hard of hearing. So we'll begin by discussing the method that was used in this article. The outcomes of children with hearing loss is a 5-year multinuclear investigation, and the children within this study had a permanent bilateral hearing loss with better ear pure tone averages at 500, 1,000, 2,000, and 4,000 hertz. And this was between 25 and 75 decibel hearing loss. None of the children had additional significant sensory or developmental challenges, and all had at least one primary caregiver in the home who spoke English. And the current study involves a subgroup of parents and early interventional professionals of 122 children ranging in age from 6 to 36 months at the entry of the study. And infants and toddlers were seen 6 months until 24 months of age and annually afterward. There were 2 groups of adult participants, and the first group consisted of 122 parents or primary caregivers of the children who were enrolled in the study. And the second group was composed of the families of early intervention professionals who were asked to complete online questionnaires each year, and they were asked to complete these each year that the services were provided to a family who was enrolled in the study. And in addition to standardized tests and also non-standardized test instruments that were administered, several questionnaires were designed to elicit a range of information from the families and professionals. The first type of questionnaire that we'll discuss is the family interview questionnaire, and this is composed of sections with questions regarding household characteristics, current early intervention services, caregiver impressions of the services, and also additional services. We also gained information on child care, the child's disposition, and a source of the parent's support during this questionnaire. The duration of the questionnaire was about an hour, and it was completed with the parent or caregiver, and it was scheduled approximately 6 months after each child's yearly study visit. The next type of questionnaire is the service provider questionnaire, and this is the birth to 3 version. This is an online instrument, and it was completed annually as well by each child's service professional. And this consists of 6 sections, which are characteristic of services provided to a family, caseload characteristics, provider preparation, professional experience, and also confidence in providing services in these specific skill areas. Next, we will discuss the results of our study. And most of the data collected from these surveys were categorical. The data reported in this section, they're based upon information from family interview questionnaires and regarding the setting in which the early intervention services were delivered. and also how frequently a family member was able to participate in those services. So as you can see, the early intervention settings and family participation has two categories, and the first is services in the home. And this is when the respondents reported that services were delivered solely in the home. And among these families, the proportion of the home-based only services decreased across the respective age categories. So across all ages, the level of the family member participation with their child and also the early intervention professional was described as always or most of the time for 95% of the families receiving the services in the home, and none of the families reported never participating in home-based services. All right, so for services outside of the home, 18 of the families, which would be almost 10%, reported that early intervention occurred only in a non-home setting, and 21% stated that they had received services in both home and non-home settings within the year of the family interview. So services in the non-home settings were provided in places such as daycares and centers for children with special needs and other situations such as those. And compared with the home-based settings, family-level participation was more variable for services outside of the home. And when services were delivered in non-home locations, such as daycares that we discussed, the parents' participation was rated as always or most of the time. So of the non-home locations, family participation was more frequently rated always or most of the time for the therapist's office or the clinic setting. All right, so now we will talk about the description of professionals providing early intervention services. So the first category is caseloads and experience within early intervention. And this is just talking about the caseload sizes, and they range from as few as 1 to as many as 60 children. And the average total caseload was about 20 children. So slightly more than half of the participants reported caseloads composed of entirely children with some degree of hearing loss. And next is the highest degree and degree areas. So this is just discussing what the respondents' degree areas are. And among this group, 18.5% had a bachelor's degree, and 80% had earned a master's degree, and 2 providers had doctoral degrees. So a little more than half had a degree as a teacher of the deaf or hard of hearing, and 1/3 had degrees as SLPs. As far as certifications, with the exception of the individual who did not earn a degree in an area related to hearing loss or early intervention, all the professionals were certified in their degree area. Okay, for professional development and continuing education, 61% indicated that they had participated in relevant continuing education, and 22 participated in a half or full day in service training. All right, for the provider self-assessment of comfort level, this is just when each respondent was asked to indicate their levels of comfort on 18 skill areas associated with providing service to young children who are hard of hearing. So early intervention providers rated their comfort level on a Likert scale ranging from 1, which was no comfort, to 4, which is a high level of comfort. And nearly all of the responses ranged between 2 and 3, regardless of the respondent's specialization group. For relationships of caseload composition and experience to provider comfort, these results showed significant relationships between the percent of children who are hard of hearing on a professional's caseload and self-reported comfort with each skill except developing sign language. And for relationship of specialized preparation to provider report of comfort, it turns out it's the case that the reported comfort levels for the 18 skill areas have a large correlation with each other. In fact, the correlations are generally between 0.40 and 0.80, which is pretty highly significant. And this was, of course, except for developing sign language skills. And developing sign language is not significantly correlated with the comfort level of any of the other skills. So now we will discuss the conclusions of the research article. And it's pretty straightforward. The findings indicate that families are less likely to be involved in early intervention when it is delivered outside of their home. And also the caseload composition was significantly associated with early intervention professionals' comfort scores. The results suggest that access to hands-on experience when working with children with children who are hard of hearing, it contributes to the professional comfort. And the comfort scores, the differences in these scores were reported, and early intervention professionals' self-efficacy in the areas that support access to the audition may increase the likelihood that they were more effective in empowering the parents to manage these tasks or skills, and also that parents may be better prepared in their journey towards supporting optimal speech and language outcomes for their own children. Now for the impressions. Overall, I thought that the research was thorough. It provided a lot of information. I never had any questions as far as the results and conclusions section. It just all came together, it seemed like, and I thought it was important in the application of clinical practice because knowing what best practice is, we always want to practice best practice, and I think it's important to know the environment in which the family and the child or the client is most comfortable and will make the most success. And I think this research can be applied not only to the hard of hearing or speech and language, but to other areas in the medical profession as well, because you always want your clients to feel comfortable and in their own element. And I also think it helped me to better realize the importance of a setting when it comes to early intervention. Like I just said, we always want to practice best practice, and early intervention, I feel like, must be a team approach. As SLPs, it's our job to communicate with other professionals and also communicate with the parents and provide them with strategies that not only they see us using in therapy or maybe in the home if that's where we're doing the therapy, but we need to provide them with strategies and instructions on how to implement those strategies when their child is not with the therapist, when they're at home, and that will just facilitate the success of the child. So I think that's also important. And I've just listed some pros and cons. I thought the article was well written. It was easy to read and understand for the most part, and I also liked the use of the questionnaires. I just feel like they're more personable than a standardized test. Information is applicable to clinical practice related to early intervention, which kind of relates back to what I just said in the impressions section. And the cons or limitations, I thought there was a lot of information in the results section, and it was almost a little overwhelming at first. So I thought that could have been condensed maybe in a certain way. And then there was not enough elaboration on the types of standardized tests that were used in the study. And also, because of the way the questions were worded, it was not possible to determine with confidence the proportion of services received in each location. And the study population was limited to children with no other developmental challenges and who were in a family with at least one parent who was a fluent English speaker. And so they're not representative of the heterogeneous population of children who are hard of hearing. And like I said earlier, it was difficult to determine the exact type of the study. So that is the end of my presentation, and I hope you enjoyed it. Thank you.